Good morning, everybody. Today, we are again in the Saturday class, and this is a Heartbeat Foundation as well as Care Hospital presenting the device related questions. And each time we are discussing some of the algorithm which is there in most of the pacemakers and how the device reads from the different company to company. Some companies having a different way of identifying the arrhythmias. So today we will be discussing regarding one of the commonly asked question in the IBHRE also, as well as important topic we call as a pacemaker-mediated tachycardia. And today with us is Mr. Madhukar Reddy. He is from Boston Scientific, and he will be giving the presentation regarding the how their system means how their pacemakers are identifying the PMT and what are the protocols it follows to terminate it or to prevent it. So over to Madhukar. Yeah. Okay. Over to.
Good morning, sir. Good morning, all. So, thank you very much for the opportunity, sir. Today, I will take you through the pacemaker-mediated tachycardia. It is one type of arrhythmia, so that we can call it as. So, the meaning of the pacemaker-mediated tachycardia is it is also known as the endless loop tachycardia. It is a type of arrhythmia that can occur in patients with dual chamber pacemakers only, and it's a reentrant tachycardia where the pacemaker initiates a ventricular beat, which is then conducted retrograde to the atrium, triggering the pacemaker to stimulate the ventricular again. So it is creating a loop there. It's a continuous loop. So that is how the TMT occurs. So this is the typical. I will take you through that slide again after some time. So these are the common symptoms. The patient may experience palpitations. Patient may experience dizziness after the pacemaker. So chest pain, syncope, or even sometimes heart failure symptoms as well. How it happens? So pacemaker, majority of the time, so the PVC is the culprit to initiate this pacemaker mediated tachycardia. Pacemaker ventricular beats conducted backward to the atrium, either through the AV node or through the axillary pathway. So the retrograde depolarization is sensed by the pacemaker atrial lead. Pacemaker then delivers a ventricular stimulus after its programmed AV delay. So this sequence continues. So that's the PMT, and this is the mechanism how it happens. So these are the most common initiators for the PMT in a pacemaker, which is PVCs, premature ventricular contractions, and atrial undersensing, loss of atrial capture, myopotential tracking, premature atrial contractions as well. So sometimes I will show you one of the examples. So the backup pacing in during the threshold test, that is also one of the recent initiators for the PMT can happen. So if you closely have a look, so in the what is retrograde conduction? So the conduction will travel back towards the atrium in a if you look here, like I think it will be able to, you will be able to understand here, like no worries, sir, no worries.
Yeah. No, it isn't. And here you have to. This is Roy. Yeah, okay.
So you can see here the back. Not moving, sir. This is the one, right?
Yeah. It is coming. No? Best is इसको use करो.
Yes, sir.
इसको
Change the slide. Sir. So once the impulse traveling back from the atrium to the through the AV node, it is going back. So this is how the retrograde conduction will happen. It may be through the normal conduction, which is the AV node, or the axillary pathway. So those anything can be possible to take the uh, impulse back towards the atrium. So in the timing diagram, in the timing interval, uh, typical the pacemaker thing, like you will be able to see the atrial pacing here, followed by after AV delay. So the ventricular pacing is happened, and maybe this patient have some lower rate about 45 50. There is a long gap here, and it paced here, and after that, so the ventricular pacing happened. So this is the normal phenomena of a pacemaker. After that, so there is a PVC. Once this PVC, if you closely look at the blue one, so from here the atrium was retrogradely conducted. This is the culprit. The PVC is culprit here to initiate this pacemaker mediated tachycardia. So it starts again. So atrium, after that AV delay, so the ventricular pulse will come. So retrograde happened, and it's a continuous loop that will initiate, and it's a retrograde conduction you will be able to see here. These retrograde conductions will create some kind of symptoms or the issues to the patient while having this kind of thing. So to observe this, to confirm this whether it is a PMT or not, so these PMTs, majority of the time all these PMTs will occur at a maximum tracking rate. So this is the timing diagram of a typical pacemaker. So you can see the pacemaker will calculate the lower rate from the ventricle to ventricle beat, or the atrium to atrium beat. This is a maximum tracking interval. So the PVC is initiated here, and you will be see all the AV delay, atrial extra impulse, PVAP, which is post ventricular atrial refractory period and ventricular refractory period. For our understanding, so this is the ventricular paced beat, which was marked as V, and this is the sensed beat, which is a PVC, which was sensed by the device. Sir, so these are the protections or the treatment options through the device to terminate the pacemaker mediated tachycardia, which is long PVAR, which is post ventricular atrial refractory period. Lower the maximum tracking rate. Sometimes it helps. Automatic PVARP extension after a detected PVC. This is the in present generation devices, each and every pacemaker has this algorithm, which is once the device detects a PVC, and the PVARP will be extended automatically to avoid the endless loop tachycardia, which is PMT. So these are the very basic and important rules that we need to understand while programming a device. So TARP is very important factor to analyze and to make the AV delay effective to a particular patient. Example, so the PVAR plus AV delay, which is equal to TARP, typically it is about 400 milliseconds. So determines the AV block. So where the patient is going to have the AV block for a particular patient. Example, if you have a PVARP of 250 milliseconds and 150 milliseconds of AV delay, which is 400 milliseconds of TARP, and 2:1 AV block will happen for this patient at a rate of 150 beats per minute. However, if you increase the PVARP to 350 milliseconds, same as your AV delay, which is 150 milliseconds, equal to 500 milliseconds, that means you are going to have the AV block for a particular patient at a lower rate. I mean to say, for younger patients, so you need to always keep the PVARP little lower, and for older patients, typical our heart rates will be 220 minus age, which is about if the patient rate is age is about 75 80, so it comes about 110 120, just like that. So in the pacemaker, so this is the mechanism which is going to happen. So once the pacemaker triggers identifies a PVC, the PVARP will be extended automatically. Once you extend this PVARP, so the retrograde P wave will fall in the refractory period, so that it will not conduct, or it will not come into the picture for the timing cycle. And next, after the expiry of the timing interval. So the pacemaker will initiate a P wave and it will be generated P wave. So the endless loop tachycardia will be avoided for a particular patient. So in Boston, so it will vary from patient to patient, sorry, company to company. So typical Boston Scientific algorithm works in such a way: after 15 consecutive VA interval, which is the retrograde conduction, so pacemaker will extend the P warp. So once it is done, so the after 16th cycle, so the P wave will be hidden by the device, that is by making the P warp extension about 400 milliseconds, and then so it records in the histograms and the arrhythmia logbook, so that we will be able to see how many times these kind of episodes happen to a particular patient, so that later on if required, so we can adjust the AV delay as well as the P warp as per the patient need. So in summary, so the management for a PMT, so which is increased P warp, decreased maximum tracking rate. Magnet application is one of the major application, but we need to have a patient with us to have the magnet application over the device. So this is the most common algorithm, which is the extended P warp after PVC, and that is how we are going to terminate the PMT circuit. So if you allow me, sir, I will take you one of the example. So there is a patient. So this is one of the examples of Boston Scientific pacemaker. So symptomatic AV block. So the patient had a fatigue, lack of energy, and he is near syncope. So implanted a dual chamber pacemaker, recurrent palpitations. After the implant, new since pacemaker implanted. That means after the pacemaker, this patient had few symptoms, nothing like this prior to the pacemaker implant. I mean to say, the symptoms before the pacemaker and after the pacemaker was slightly varying for a particular patient. So he is aware. So the awareness of sinus rates that were previously precluded by CHB. So this is not the same case. So inappropriate AV delay, all these things will be there before the thing. So occurrence of a spontaneous atrial tachyarrhythmia that capable of being tracked. So all this is in a favor of pacemaker mediated tachycardia. So it is an independent pacing system. So you will be able to see, I think there is apologies for the clarity of this. So patient came for follow-up. So while observing the patient, so this is the loss of capture. I will show you, take you to the next slide. But asymptomatic at this time. So patient had a loss of capture in the atrium, but it is patient is asymptomatic. So it is going to the next slide. So if you carefully look at, so this is a typical strip of a threshold test. So capture confirmed here, loss of capture even after that. So if you look at the intervals, or if you look at the QRS complexes from one place to other, after loss of capture, so there is a the QRS complexes came very near compared to the threshold test. That means something is happening here, something is initiated here. So this is the present day. So this is the most common trigger in the pacemaker segment. After the threshold test, when there is a loss of capture, when you deliver a pulse which is not able to capture, that is the loss of capture during the threshold test, but that sometimes initiates the PMT in a patient, and he will experience the palpitations, and you will be able to see here. So here the coincidence of the onset of tachycardia with the programming change that is stable between V pace and the next P wave. So this is the common thing. It may happen, so you need to be careful sometimes. So you may present days like we are doing with the programmers without the ECGs. So I request each and everyone to do the regular follow-up by connecting the ECG, so that you will be able to understand what exactly the thing is happening, and you will be able to see in a better way to understand what exactly it is happening. So this is a true typical pacemaker tachycardia was initiated at the time of the loss of capture. So this is in plot diagram. So this is the backup pace which was happened, and after that, so there is a retrograde conduction which is initiated. So far all these days, like we will see that PAC or PVCs are most common thing, but even during the threshold test or sometimes midnight or patient at rest, depends on the companies. So the atrial threshold or the ventricle thresholds will happen. So even in that case, so there is a possibility that patient will have this kind of pacemaker mediated tachycardia. So we need to be careful while we do the follow up to check the patients. So sometimes the patient may tell you that I had these palpitations during this time. It may be at this significant time when the exact time when the threshold test ends, or when the patient device does the automatic threshold. So this is the most common factor nowadays, for your understanding, to understand in a better way. Not only the PVC, there are many other factors as well. Is one of the major factor for the PMT initiation.
So, any way to identify which patient is going to develop PMT? How you means whenever you are implanting, so you must be saying to your colleagues or whatever persons who are interviewed that always go and check these things before after the implant and say that after that yes, this patient can have PMT and activity. Is it default activated or if it is default?
Default, it is activated in all the companies, sir. Okay. So there is.
So how to identify it?
So normally, sir, so when we do the implant, so we need to carefully look at the ECG by checking the VA interval. If you have the VA interval and over a period of time, even when the patient comes back for the follow-up, all these measures needs to be taken care. If you have a active, or if you are active with the patient, so if you carefully look at the VA conduction
So
time.
how are you going to see the VA conduction in your
So in our programmers, we can initiate VA conduction by doing the retrograde conduction test, and we can do that, sir.
So you are doing routinely?
Routinely nowadays, sir, routinely we are not doing because of the what do you call, the rigorous programming from the device side. But the majority of the PMTs are subsided compared to the olden days, because nowadays all the companies they gave an option that either the PVARP or the AV delay automatically adjust based on the patient profile. So you will be able to see very low in number of PMT episodes now by recording the device.
If somebody has deactivated due to some reason, maybe the patient is having AV not tableted and they are having suspicion problem, the patient may have the they have deactivated and the patient is coming with that. So that's why it is essential that
Yes.
Any palpitation. Thank you.
Thank you, sir. Thank you very much.
So far we have discussed regarding the PMT. So let me summarize the things. So PMT is a device-initiated tachycardia. Means the patient is not having its own tachycardia, or you can say clinical arrhythmia, but it has been. So patient is not having. So patient is not having clinical arrhythmia, but patient is developing the tachycardia. And in this situation, what we are supposed to know whether the patient is having any clinical arrhythmia, and which has been tracked by the device, which is possible in the dual chamber pacemaker. Now we will be touching on the points what he told that patient's tachycardia has been sensed that VA conduction is happening, and this VA conduction is leading. So let me first explain what is VA and AV conduction. So normally sinus is activating it will go through the AV node, and then bundle of his, and then right and left bundle. This is a normal conduction that we all are knowing. But we should know that there is possibility that from ventricle, if any VPC is developing, it can go up to the AV node, and later on it can go to the atrium also, and there it is going to activate the some type of tachycardia, or sometimes we can say resetting of the sinus node. So compensatory pause, non-compensatory pause, what we call as a incomplete versus complete compensation, means the AV is compensatory, means it is reset the AV node, sorry, SA node. Then the pauses between the VPC versus APC will be totally different. Complete versus incomplete. Compensatory pauses, we use the word. I'm not going in detail in that one, because just you should know that any VA activity, ventricular activity, can lead to resetting of the sinus node through the conduction through the AV node. So, so through the ventricle to atrium and resetting the. Now coming to the second part, please switch off or silent mode. Second part is complete heart block. We use CHB. Means the conduction is not happening from the ventricle to atrium. This is the commonly we are known. But what is the possibility that ventricle to atrium conduction is happening in a patient of complete heart block? Any guess? AV block is there, all atrium is dissociated to ventricle, means ventricle is beating its own, atrium is beating its own. So in that situation, what will be the, means what is your possibility, that how much possibility is that VA conduction will be there? It is 0%, 10%, 50%, 70%. 10%, how you know? No, there is no need of accessory pathways. So you are not seeing the slide. He has given the slide, and very clearly he has written also. You have not gone through it. So in that slide, it was showing it. It was around 10 to 15%. There is a retrograde conduction. Means AV conduction is not happening, but anytime VPC is there, due to any reason, it can conduct. So patients with complete heart block are not immune to PMT. This concept should be clear. If a patient, you are implanting a pacemaker and you are thinking that he will not develop because there is no AV conduction, don't expect the VA conduction will not be there. It may be possible that 10 to 15% of patients may be having. So this was the important concept that we have to know. Diagnosis of CHB, PMT is still possible. Now, second part is that, can it be happen in a patient with only DDD or VDD? Both it can happen. Na? So single chamber and VDD mode, it is still possible. But single chamber pacemaker, it can happen? No. Why? We don't have any evidence. Yes. So PMT as such, it is not possible in the. So these are the important takeaway. And what is the thing on which you have to first keep the diagnosis that it can be PMT? What is the mode, or you can say what is the ECG diagnosis? Whenever it is heart rate is going, what are the two things you are going to check before saying that it can be PMT? After that, we will be coming on the differential diagnosis. Yes, very good. Next. No surface. No. Anything more? A sense V pace. This is the first thing, and maximum tracking rate. If it is going on, you have to think that you may be dealing with a PMT. So V pace should be there. V sensing is not going to air. A sense should be there. So upper rate behavior with A sense V pace until proved otherwise in a patient, and if it is a sudden onset, it is a possibility that you are dealing with a PMT. So multiple choice questions will be coming all the time. Even in if you are going in IBHRE, they will make a lot of permutation combination, lot of lengthy pretext regarding the case. And if you are not focusing where to see, because there are two behavior, one is lower rate behavior and higher rate behavior. Yeah. So this is a higher rate behavior of the device. Means upper rate behavior. So when the heart rate is going up, these are the behavior we can expect in a dual chamber pacemaker. Okay. So now we will be going to the second part, that is the question part, and I think everybody is ready. No, I will connect. I have not connected right now. So whatever we are reading, we have to again come to the question part. Okay. Let me come. Not coming. Okay. Second part now. Yeah. Why it is not coming? स्टक अप हुआ है इसमें. Okay, it will come in the window. But it is giving the answer also. That I don't know it. एसी ऑफ किया हुआ है क्या इन लोगों ने? हाँ. Not coming. Uh, 70-year-old patient with dual chamber pacemaker. Present is palpitation, interrogations with sudden onset tachycardia, 120 heart rate, upper tracking rate, stored EGMs with PVC followed by retrograde pain, initiating the tachycardia. What is the most likely mechanism? Atrial oversensing due to the lead noise, ventricular originating from the RV apex, PMT or sinus tachycardia with 1-to-1. चलो इसमें nothing very significant to tell you. So the scenario is very important. Whenever it is happening, sudden onset is the most important part that we should learn, and PVC followed by retrograde P wave, and PMT re-entrant tachycardia. So it will be sudden. So whenever anything is happening sudden, we think about that it is a re-entrant. And tracking of the P wave, P wave may not be visible, but if you are seeing that it is a regularity of this is there, we should keep a possibility. A patient with a dual chamber pacemaker which has a recurrent PMT, the device is currently programmed at PVARP of 250 and VA conduction is 280. Which of the following programming change will most effectively prevent the PMT? I think it is very easy for you. Yes. So always we act on the PVAF. So 300, you have to do it. So VA conduction, whatever the time, you have to add 20 or 30 and it will be done. So PVRP determines the when the atrial channels can sense after this one. So what is the difference between the blanking period and refractory period? You are having two periods. One is blanked and one is refractory. What is the difference?
It is not responded to any signal in blank.
Okay. Pardon?
In refractory, it will respond.
Refractory will respond. Okay.
Refractory will see it, but it will not respond.
Case in which you are saying the responding.
It will not sense or it will not see anything. Sir. Refractory it will sense, but it will not respond.
Yes, you are correct. So two things are there. Blanking means totally blank. It is not going to see anything what is happening. In that period, it is totally off. Off means the timer is neither alter nor it is going to check any activity on the channel. Means the lead is there, but it is totally off for that particular period. Not sensing, not seeing, nothing is there. When it goes into the refractory period, it is going to watch what is happening, but it will not take any action. The timer can be it is not going to reset the timer, because if you know all the pacemaker, it is a timer, lower rate behavior. Okay, after that this is going to come. But anything which is falling in the refractory period, it is not going to work on the timer of the pacemaker. It is not going to change anything. It has sensed, okay, it will later on say we are seeing some VA activity, but it is not going to change anything. So this is an important concept between the blanking versus blanking. We want to do when any pacing is happening, that time the other lead should not sense anything. For that, the crosstalk has to be avoided, and that's why it is kept in the pacemaker. Question number 3. A patient with dual chamber pacemaker develop PMT 130. The nurse places a magnet over the device and the tachycardia stop immediately. So what happened when the magnet is being kept? Yeah. So this question is basically meant that when you are in the periphery and you are not able to, you are sense the ECG is going and somebody has called you, and you the doctor is not there, or even you are not having the programmer, how to terminate the tachycardia. So put a magnet. Wherever you are in trouble, magnet is going to save. And if you are having iPhone 15 plus, they works very well, at least for the Medtronic devices. So when you put, it will reset it. So that is so powerful, the magnet part is. So if you are not getting magnet, at least try with that one. So it may help to reset the device. So magnet, I think some 20 Gauss magnet should be there, and it work on the reed switch. So reed switch is going to just make, you should not do anything, just pace. That is the thing, it's going to give the direction to the pacemaker. Pacemaker is a robot. It has been given two directions. You should sense and then work. Sense, work, sense, work, like that. But the time you are putting a magnet, it is giving direct in the, don't see, just do, just fire it. You are not supposed to see what is happening, what information. You have not to gather the information, you have to fire only. So it will be firing. So more firing, more battery loss. And when you are putting the magnet on an ICD, what will happen? There is a difference between both the things. Therapy means VT-VF therapy we have kept in the patients. So VT-VF therapy, what is that? It will be going to be ATP. It can go and give the shock. So if your patient is giving a lot of shocks and you are outside and the patient is outside the hospital setting, you are not having the programmer. What next? You put a magnet, paste it, and bring the patient to the hospital. Because recurrent shock are mostly inappropriate shock. Inappropriate means it is not for the clinical arrhythmias. Sometimes device-related detection algorithm has been failed. Maybe atrial fibrillation is going on one shock, your adrenaline level has gone up all of a sudden, and after that the heart rate is going again fast. So atrial fibrillation with fast ventricular rate, where the atrial fibrillation protocol or algorithm has not been activated. The branching point A versus V has not been totally identified by device. Device is not understanding. It is saying ventricular rate of 200 above is taken as VT or VF, or sorry, VF. It started giving shock. But the ventricular rate of more than 200 is still possible in atrial fibrillation with fast ventricular rate. So it is AFib for which you are giving shock. So device is not supposed to give shock for atrial fibrillation. It is only and only for VF or the VT, which is unstable. Unstable means the patient blood pressure is dropping. In those two conditions, it should start with a default shock mode. Otherwise, it should go for the ATPs, terminate the tachycardia, not terminated, give one or two, not terminating, shock it. This is the usual protocol for the ICDs. But if a patient is developing 2 or 3 shocks and he's still getting a third, it is one of the most difficult situation or life's challenge for a patient who has been implanted device. He will say, you should kill me, but take out this device. And you are not in the state to put a magnet, transport to the nearest center, get the device interrogation done, and if the device interrogation is not there, anesthetize the patient. This is the usual. Anesthesia means you have to knock out the patient, giving the general anesthesia, let the patient sleep. And put the patches from outside. If the VT is coming, you have to terminate it. So this is a medical emergency, we all should know, and magnet is going to help you. So all the persons should keep one magnet who are in the medical field and working in the cardiology. It will certainly save some patient's life. Okay. So a pacemaker patient presented with tachycardia 140 upper rate. There is ECG 1-to-1 conduction device diagnostic. So atrial rate gradually increasing before tachycardia. What is the most likely diagnosis? What is the answer? See, the answer is there, na? Gradual. Always read the word. See, it is presenting. See, the question. Diagnosis, so atrial rate gradually increasing before tachycardia means it is sinus tachycardia is happening and after that it is taking it. If a patient is having complete heart block and sinus tachycardia is happening, it will go. Na? So gradually, if it is sudden, then you have to think about the PMT. Okay. So sinus tachycardia and PMT is sudden onset and usually by the PVCs. And finally, the last question. A pacemaker patients with pacemaker programmed with a PMT intervention on. During the follow-up, the device shows one PMT episode that self-terminated after 10 cycles. How do the pacemaker most likely terminate the PMT? So, withheld one VPC after detecting the rapid stable VA association, delivers anti-tachycardia pacing, switch to VVI mode temporarily, increases the PVAV only after the magnet application. You are correct. So withheld, wherever what Madhukar was saying, nowadays the device is smart enough to understand what is happening. It has been already been ingrained in the device where to give the therapy. Means it is seeing PVC, immediately it is increasing. Rest of the time it is just watching. So device is so sensitive, it is seeing every VPC and behavior. So the time it senses VPC, it has already been on that it is going to add on some PVAP of you, it is 280, it will go okay 40 millisecond 320. There is no chances of having PMT. So PMT initially require retrograde P wave and atrial sensing. Without atrial sensing, it can't be possible. PVAP and DO mode. Now, before going, one important part I just wanted to touch. So this was the today's topic what we have discussed. But pacemaker-mediated arrhythmia, this is a big chapter. Let me touch the basic important point which has not been touched here. So first of all, whenever wide QRS tachycardia is happening in a patient of pacemaker, what are the possibilities? This will be always an open question for you when you are going to the device. You are putting magnet, sometime you are able to terminate. But if it is not terminated, what is the other possibilities? That we have to know. So if it is a dual chamber versus single chamber, this question has to be answered. Dual chamber, there are possibility near field endless loop tachycardia, far field endless loop tachycardia, tracking of atrial arrhythmia. It can be atrial flutter, it can be atrial tachycardia. Atrial fibrillation is usually not the tachycardia which is going to be tracked. Device get confused for two rhythms. One is atrial flutter and second is atrial tachycardia. Atrial fibrillation, it is having a clear-cut guidelines. So atrial fibrillation VVI mode over and out. But flutter and atrial tachycardia, it is not going to differentiate because the rate will be in the physiological range. Okay. Sensor-driven tachycardia means and run-away pacemaker, repetitive non-reentrant VA synchrony. Have you heard about all those things? Sanjeev is saying yes. Tell me, Sanjeev, what is run-away pacemaker? Run-away pacemaker. We've already taught.
Pacemaker malfunction.
Yes, good. Run-away pacemaker means why it has been kept, we don't know, but in the initial, when the device has been invented, initial eras, or you can say initial years, the device implanted, that patient is doing fine, and most of the time these are VOO mode. Later on, it has gone VVI mode. Like the evolution has happened, but initially the circuits are not that robust to be predictable. The predictable behavior is it should pace according to the need. There are some situations in which the device has become unpredictable, run away with their function. And this is a functional malformation, and it is a severe function malformation. It has been supposed to pace at a rate of 60, 80, 100, 120, 130, whatever the tracking rate you have kept. But there are some circuitry issues in which it start pacing at 200, 250, 300, 400, 600. And you can think about the heart, which should be supposed to heart beat at around 100 to 120 to going to maximum 200. It is beating 300 and 400, and that is ventricle. So pacing a ventricle at 400, what will happen? VF happens, syncope happens, cardiac arrest, everything can happen, and this is device induced. So this is called runaway pacemaker. And what you have to do?
Disconnect.
Transport the patient. If possible, transportation is not possible, just cut mark, take out the pacemaker. If you have diagnosed, well diagnosed, you are seeing the heart rate is going 200, 300, it is a totally a pacing. Don't think about as a life saving. If it is a dependent, you are nothing. The time you cut, he will go in the arrest. So ideally, it should be brought to the hospital, put a temporary and cut down the wire. And that should be happen like a primary angioplasty. You should not wait that, okay, the patient will be shifted. You are seeing that patient can die anytime. So there is no way out unless you are not cutting the wire. It is not, or descrewing the wire, you are not able to do it. So runaway is a medical emergency, surgical emergency in the pacemaker. Now, single chamber sensor tachycardia means sinus tachycardia can be tracked. I was saying the sinus tachycardia is their complete heart block. So all the rhythm is not coming due to some reason. Maybe some drug has taken cough syrups, which is very commonly cough cold. Not reducing, they have given some beta agonist, means they are nebulizing, and on top, they have taken some cough syrup. So heart rate will go up, and you will see the pacemaker started beating at a sensor rate. Whatever has been kept higher, it will start beating in this one. So sensor driven pacemaker are one of the condition in which the sensing, slope has been kept somewhat more steep. Immediately it will go on the higher side.
Yes,
So
minimal activity, so the sensor rate will be
yeah.
increased.
So it depends what you have kept, and in those situations you have to again try to understand. So how to differentiate? First of all, near field endless loop tachycardia versus far field endless loop tachycardia. Have you heard about this terminology? Huh?
Sir.
Near field endless loop tachycardia versus far field endless loop tachycardia. What exactly it is? Yeah. So near field means what you have taught that the VA conduction is happening from ventricle to atrium, the conduction is happening. In that situation, if the patient is having tachycardia, so that is called VA. But far field, it is possible that the far field R wave is being sensed by the atrium. So that is called far field atrial. In that situation, there is no need of changing the PA or PVAR. You have to see the blanking period, or particularly that it is also going to respond. It is behavior. Behavior is VA conduction, true VA conduction, either through the AV node or through the pathways, is driving the tachycardia. And if the far field R wave is sensed by the atrial, it is more like a cross type of situation, but it is a VA conduction. So it is very difficult to say, means when the atrium is being ventricular activity is taken as a atrial activity, because the the what you call atrial pulse, atrial lead is near to the ventricle. So this can happen. So that is called far field inless loop tachycardia. So this is the important thing, that sensed signals, true retrograde P wave will be there and far field R wave over sensing will be there. Lead related correctly sensed atrial signals will be there. Here the mistakenly sensed ventricular signals will be taken. Common trigger PVC and retrograde conduction either through the pathway or through the what you call this AV conduction. Here the ventricular pacing intrinsic R wave is responsible for that, and management P valve extension and magnet here reduce the atrial sensitivity. So whatever the sensitivity is, just reduce it so that it should not sense or sometime lead positioning. Clinical approach. So just now, whatever we have discussed right now, how to approach. If the heart rate is about 200, think about you are dealing with a runaway pacemaker. What you have to do? What just now we have done. Does the patient put a magnet and see what is happening? So if terminate, it is a PMT. No, but slow to the magneted, sensor driven. No change, runaway versus NRS.
How many seconds we can put the
Pacemaker?
pacemaker?
Magnet. Anytime.
How many seconds we can keep it?
How long that we need to put it on the pacemaker?
If you want for the PMT term is a one time, it is over. It is like giving adenosine. You have just off the sensor because it has initiated by the VPC. It has just been sensed and it is just making the VCS circle. So adenosine, when we are giving PSVT,
One beat termination is enough for the magnet.
just once dysynchronous is needed. After that, everything is open. What is happening? When it is every time it is sensing the retrograde activity. So you have to just mask one VA activity. That is enough. It is terminated. After that, again VPC comes, then only it will be starting. Okay. And no change, runaway and NRS. NRS means non-reentrant, what you call VA conduction. I will come on to this. And is there one-to-one conduction is synchronized there or not? If it is yes, then it is a PMT, and no, then it is a NRS. These are two possibilities. So PMT, sensor-driven tachycardia, and NRS, non-reentrant VA synchrony. This is one of the not commonly discussed, but it is a totally very important device-related behavior which we have to know when we are dealing, you are giving, somebody will call you, is that the patient is having APAC is coming, but there is no P waves. And there the problem is NRS. This is called NRS, non-reentrant VA synchrony, because it is falling, what you are saying, it is falling in the blanking period. So already it is, what happened, there are two behavior. One is falling in the VARP, means post-ventricular PVAP, in and out. If it is falling in, it causes NRS. If it is falling out, it will induce the PMT. So these are two behavior, and both behavior are opposite to each other. One behavior we usually be having A sense V pace, okay, that is PMT. In NRS, that is a non-reentrant VS, it is lower rate behavior. First of all, it will be pacing at its own rate, but it is pacing at the time when it is refractory, because the PVC which has given the ARP, atrial conduction, it is already depolarizing the atrium. So it is in the refractive period. You are giving pacing, it will not happen. And you are seeing the rate is not going to increase to what maximum tracking rate in the case of NRS. It is just a non-conduction of the PM. So non-capture, if it is happening after PVC, mind it. Non-capture after PVC can lead to NRS, and if it is happening outside the PVAP, it is going to PMT. So two behavior, one is lower rate behavior, other is upper rate behavior. So always see what is happening after PVC. If it is a high rate behavior, PMT. If it is a low rate behavior and non-capture of the atrial activity, it is a NRS. Okay. And runaway pacemaker, I think this has been well defined. So this is the thing I was saying. If VPC is happening and it is passing this PVAP outside, it will be PMT. If it is falling here, means VA conduction is happening and it is falling here, it can activate NRS. Is it clear? NRS will be lower rate behavior. Whatever 60 rate you have kept, same 60 rate is going on, but there is no pacing. And this is the thing what Madhukar was saying. So VA conduction can happen through the down to up through the AV node, or it can go through the pathways, either of the things. If pathway is there, we have to ablate it also in those situations. But if it's through the AV node, usually the timing, you can just play with the timing, it can fall in this one and you can terminate it. I think this has been already been covered. So thank you, everybody. Yeah. So next time we will go for crosstalk. This is a very important topic, which will be and the streaming. Yeah.